Buonasera, benvenuti a GiovedìScienza. Saluto qui al pubblico.
Welcome to you all. Good evening. Welcome to you, GiovedìScienza and Piero Bianucci.
Buonasera a tutti. Sto per parlarvi di una scoperta di genetica.
I am going to talk about a discovery of genetics which was recently published on a botanical journal. The University of Milan wrote. This institute worked on a gene which is particularly good at multiplying the petals of flowers. And in fact, flowers should have 5 petals, but you know that with various hybridizations and other things, we have managed to increase the number of petals. So what did they do with this gene? Taking or analyzing a genetic bank and seeing how this gene was switched on, they managed to keep it on for longer. So this gene that normally produces some petals, they tried it on carnations, on roses, on petunias, so they kept it on longer. So these flowers multiplied the number of petals. So it is called the petaloso gene.
Grazie Piero.
Thank you very much, Piero.
Sembra anche che con un ardito
And with a link, we can connect this to the topic of the evening. Thinking of flowers, romanticism as a literary current, and heart. Heart is what we're going to be talking about. Heart is it's not St. Valentine's today, but it's very close. And here I can also refer to my memory bank. The first heart transplant that Barnard did on Washkansky was one of the first science-related news that I had to deal with when I started in 1967 working at the Gazzetta del Popolo, the newspaper. The news of that transplant was not so important, but I remember that there was a debate which gives us an idea of how people didn't know much about science in Italy at the time. But I'll tell you what was said then. You will be, I think, surprised, because the heart of a woman was transplanted on into Washkansky, and there was a debate amongst journalists and on television as to whether a woman's heart would have transmitted or turned his feelings into a woman's feelings. That was the cultural level at the time, but I think we have improved this.
dal punto di vista biologico. Anche se il cuore...
Yes, let's do this and talk about the heart from a biological point of view, although hearts have always been mixed in with science and literature. And please let us now call Professor Mauro Rinaldi, this evening's guest.
Buonasera a tutti.
Good evening.
Buonasera professore, grazie.
Professor Rinaldi dell'ospedale Molinette, Città, della.
Professor Rinaldi from the Molinette Hospital here in Turin, and also a professor at the University of Turin, who will be talking about hearts and the new frontiers. I was saying that hearts have always been really a symbol of many things. The ancient Egyptians started with that, or even before. This is why for a long time it was really a taboo, and the doctors touched it with great respect, very late, in fact, in the day. Yes, this is true. In fact, until the beginning of the 20th century, the surgeons used to say, "Don't you dare touch hearts." It was a saying, because you will no longer be a surgeon, because there was always this halo around a heart, so to speak. Those days, we couldn't replace the function of the heart. So what you're saying is absolutely true. But in fact, the heart is a pump with the pipes. It's run by electricity. Well, you're actually oversimplifying, I think. It is not merely an engineering problem. It's not so simple. Yes, it is true. It is basically a pump. When you operate on it, you can see it from this point of view. Yes, it is true. From a mechanical point of view, that's what it is. But don't forget how many words are linked to the heart. Words that refer to feelings, courage, or sympathy in Italian, cordoglio. And the first heart transplant that you were talking about bears witness of the fact that surgeons were at long last implementing what had been but a dream for centuries. Professor Rinaldi, who had not to do with the first operation, was part of the group that carried out one of the first heart transplant in Italy and the first heart-lung. You were very young at the time, yes, in Pavia. With my master, we certainly were some of the first in Italy, a milestone, I would say, in the history of heart transplant in Italy. So at this point, I would like to give you the floor and tell us what happened since doctors started working on the heart. Well, the heart, you were saying, is a simple pump. Well, in fact, there are two pumps, as you can see. One is a right one is a left one, and there's a system of valves. It would appear to be simple, but in fact, it is a wonderful mechanism where there are many myofibrils. It is able to beat for billions of times 20 liters of blood a minute in athletes. It has 4 valves, 4 chambers, a conduction system which is very complicated and articulated. Here you can see it is simple and complex at the same time. If you look at from the inside, there are these structures that look like architecture. This is a real mitral valve, and here you can see these tendons that maintain the tension, and this is an aortic valve which is seen from above and from below. Here you can see that it is a wonder of nature, certainly, to imitate, or would be very difficult, has been very difficult, is very difficult. Heart surgery started quite a while ago, and I'm very pleased to talk about here because a lot of people don't know. When was it possible for the first time to replace the artificial circulation? It was 1951 on August the 7th here in Turin. Achille Mario Agliotti, whose chair I now have, although I might not be worthy of it. They used artificial circulation while he was removing a cancer of the chest. And this was the enormous machine, as it was then. And here you have a report on that. The venous blood is gathered. Please notice that he's speaking Piedmontese. And here you see it's the heart-lung system. And then the blood is reintroduced through the artery with a cannula in the left upper subclavia. It worked. It was a complex system, but it worked at the time. This was the machine. And it was only a partial. It wasn't replacement. It didn't. It wasn't able to replace the heart altogether. Here's the oxygenator, and there is a pump too. And this was used here in Turin for the first time, and it has remained in the archives. But luckily, in this recent cardiac surgery book, it was recalled or mentioned on August the 7th here in Turin in 1951 was a partial replacement of a heart system.
è veramente corredata di personaggi illustri e anche un po' bizzarri.
We have to move on to the next step. He's very famous and rather eccentric, Walton Lilley. For many years it was not possible to use the car, so this heart surgeon invented something else to operate on children that are suffering from Fallot or other defects of the heart. He used a cross circulation. Basically a very simple idea. He used the father as a heart-lung machine for the child, therefore connecting the femoral vein of the parent, two beds, one next to the other in the operating theater. This was connected to the right atrium of the child and the femoral artery of the parent to the aorta of the child. So it was possible to stop the child's heart enough to correct the congenital fault. Then he operated on 45 cases, and then there was a big disaster. One of the parents died during the operation. There was a very complex of regulation of flows. Something didn't work, and the parent died. And this surgeon was tried for manslaughter, which is another classic of the history of heart surgery. Then a few years later, Gibbon, at the Mayo Clinic in Minnesota, he was lucky enough to work where there was both a General Motors and an IBM plant. This was the first heart-lung machine. You can still see it at the Mayo Clinic. It was called a heart-lung apparatus. And you can see it at the museum, as I was saying, of the Mayo Clinic. And then we started our adventure. That is to say, it was possible to replace the heart's function with a machine. Everything is much smaller. This is an operating theater. And here you see we have another system that we can use. That is to say, a surgical robot known as Da Vinci, which is what we use for operations. I will be talking briefly of these chapters. Our discipline in the past few years has been using the approach whereby you are less invasive if possible. So in most cases, until not so long ago, it was necessary to open the sternum, and in some cases it's still necessary, but in most cases where we repair the valves, and which are an important part of the work that we do, this is no longer taking place because it is possible to approach a heart thoracoscopically, or that is to say without opening the chest, with sort of keyhole surgery. It is necessary to have extracorporeal circulation, but it's mini-invasive. Here I would like to show these images. I hope they're not too unpleasant for you, but it is repairing a mitral valve in a young woman, and it is possible to cut in the right mammary sulcus. This we introduce with this port. Here the machines that we need. In this case, we need to see well, so we need a thoracoscopic device. This is the heart. You can see in the right part of the chest and the phrenic nerve. And you see it is possible to do this without touching any bone. The extracorporeal circulation is miniaturized with access from the pelvis. These cannulae, as you can see here, the patient, we have an echographic guide during the operation up to the right atrium and eliminate the blood from there. Here you can see this is a femoral artery that is where we have a catheter with an echographic guide. We have these special cannulae. This is a balloon catheter which is necessary to enter the main vessel of the heart, the aorta, and interrupt the coronary circulation. You can see once this is in position, again we're using the ultrasound or echographic guide. And when we are ready, at this point, from this position, it is possible to open the pericardium. This is the phrenic nerve, thanks to which we breathe. The heart is still pulsating because it's still working, but at this point we have to enter the cavity, so at a certain point we have to stop it. There are surgery, you see, there are lots of techniques and lots of tricks which are very important. Today, technology is more important, but skill and technique is still the human factor, which is very important. And with these devices, we can see where we have to operate. This is the left atrium. We don't see the rest of the heart. And when we're ready, at long last, we stop this heart with, you see, by swelling the balloon swells up, and I'm injecting this solution, and it becomes a cardioplegic solution which blocks the heart. Hereafter, we have 2 hours roughly to complete the operation, not much more, because after that there's damage to the heart. Thanks to this approach, we save a lot in terms of surgery, and you see in this inter-rib position we use our instruments. What you've seen is considered mini-invasive surgery, but you can be even less invasive with telemanipulators. What are they? Well, here you can see this is the robot I was talking about, the Da Vinci one. This comes from the war industry. The big investments and many of the things that you will see, in fact, are the fruit of research into weapons, because especially in the US, that's where the big investments are. This is called intuitive surgery, and it was named after the great Leonardo da Vinci. And it was seen as a robot that could be taken to the battlefield so that surgeons could operate at a distance. Here you see there is a telemanipulator. There are 3 mechanical arms that reproduce the movements that the surgeon would be doing, and which does outside, that they reproduce them inside. So it is necessary to insert the 3 trocars in the chest, and with a completely closed chest, these 3 trocars act on a fulcrum, which has to be at the level of the rib cage, and this is something we were the first ones to use it in Italy in the year 2000. It's a machine that then cost over 1.5 billion Italian lira, which is like 750,000 euros. And here you can see this is the movement of my left hand. Not only does it reproduce the movement of my left hand, but it improves it. It was enough to introduce those 3 trocars, and then from the outside, here, as me, still very young, positioning these devices inside, and this robot to make it possible to filter some of your problems. Say that your hand is shaking a bit, it eliminates it, and then it decuplicates a movement. You do a very big, easy movement outside, and it's miniaturized in the inside, so much so I am a right-hander, but I could do everything in the same way with the left and right hand. So here I am taking a mammary artery out, and you see here the mammary artery, and by doing it, here you have an amplified 3D. This is about 2 millimeters, in fact. This artery, it was closed and isolated, and you can see that with this open here, you will observe that we have to carry out an anastomosis on the occluded coronary artery so as to guarantee a normal flow. Now, this is a result of the war industry, and here you can see the anterior surface of the heart. One of the coronary is closed, is blocked, the anterior one, and this is an operation that I performed, and although I'm not left-handed, I'm using my left hand in a manner which is better than my natural one, thanks to this mechanism of magnification. This is clearly technically very simple. That is to say, there's a bypass, and you can't really apply it in all the cases that you may have to operate on. But also for aortic valve surgery, it was possible in most cases to avoid an operation of the sternum. I'm showing you this because this too is an Italian technology. It's a Sorin biomedical Sorin, which is Piedmontese, not only Italian. And this is an example of a replacement of an aortic valve with another valve, which is manufactured here in Saluggia, and which makes it possible to replace this aortic valve with a new valve that can be positioned or put in place without necessarily having a suture. So what I do is I make a hole, a small hole. This valve is then reduced. It was made out of a substance which then reopens. It's called a valve on a stick, and then it reopens. You can see there are three very simple eyes, and I pass a thread through that, or a wire, and it is then released. First we were talking about flowers. This is like a stem, and you see here it is opened, and it automatically positions itself where it should be. At that point we have a balloon to favor its adhesion to the annulus, and this is done also for elderly and frail patients. Other systems that we have with this type of technology is very strongly rooted in Italy. A colleague of mine, an Italian colleague of mine that then moved to the US, invented it. He invented this system where we go from mini-invasive to micro-invasive surgery. Very small incisions. We do not have to stop the heart, and we also eliminate the need of extracorporeal circulation. In other words, we mend a valve with a heart beating. It's a very simple system. You access it from the apex of the ventriculum. This instrument captures the collapsed valve, and it repositions it. The following step is pretty self-evident. That is to say that you avoid the subthoracical incision, and this will be present in other steps too, to access through the structures that go naturally to the heart, arteries, and veins. This is called the mitral clip, whereby it is possible to mend a valve basically through the femoral vein. That is to say, without seeing the heart. Not only do you see it, you don't even touch it. You navigate from the caver, the lower caver, the inferior caver, you reach the valve, and you position the clip. Just like it is possible, these were the first implementations, so we've already done some, performed some. You can have a cardioband mitral system rings or annuluses with this intravascular navigation system. This is yet another big development. The overwhelming majority of stenotic aortic pathologies in an elderly person can be performed trans-catheter, with a trans-catheter without stopping the heart. The principle is the same. That is to say, here, there are no real images now, they're only drawings. And going from the femoral artery, you go up. This is the TAVI, the TAVI, that is to say, it is a big development. You enter through the aorta where there is the valve that needs repairing. You swell the balloon. For a few seconds, you get the heart to go in fibrillation for a few seconds, and you can do that. And then the heart starts working again, defibrillation. And this means that we have a valve on a balloon. It's a steel valve, which is crimped, as you saw in the previous video. It has to be positioned, it has to be perfect, otherwise the coronaries will stop, and you open it, and it looks again like a stem and a flower opening up. And this nowadays is really very effective. All this requires this sort of operating theater. The new operating theaters are what are known as the hybrid ones. The operating bed is at the center and everything rotates around it. This, as you can see, is for imagers. It can give a perfect radiological image of what we're doing. It can also be oriented in any way you may wish. And around this, you see, we have monitors, yes, so high definition ones, but we have a number of professionals, surgeons, cardiologists, radiologists who work together. And at the center, you have the patient, the person who is in need, the person who is coming to be treated. In this sense, this is a very humanistic vision of medicine. I remember that sort of arguing with some other people at university when I was a student. I used to say that medicine was the most humanistic of all faculties. It studies humanities and humanity. This is the operating theatre that we inaugurated a year ago at the Molinette. It has this image merging system or image fusion. You have images from radiology and from other systems, such as the echo system or the ultrasound system, and you are able to fuse the two images. You can merge the two. You put them into one and synchronize them. And at that point, it is possible to operate on virtual images, which are as precise or even more precise than the real images. This is performed without us seeing what is happening inside the heart. This is a hybrid last generation or latest generation image, and luckily now it is working at 100% of its potential. Here you can see these virtual images make it possible to simulate before the operation what is going to happen. Here you can see we have a reprocessed CT scan and other images, and we can simulate and we have many measurements and many models of valves. One was different from the other, and we are able to select the one which is best suited for the patient's anatomy without, in fact, seeing directly. Another very important one has to do with heart failure. And look at this video now. This happened. It was the Spanish championship a year ago. You can see these are ventricular tachycardial recordings. And at this point, you have a problem of time. Here there was no defibrillators, as happened in Italy not so long ago, or it doesn't work, and you can see that slowly the heart activity it becomes disorganized, and soon after the ECG is flat. So the problem of sudden cardiac arrest is a big one. 17 million deaths a year, and not only elderly patients, but also a lot of young people. We have about 10% mortality rate for every minute after a fibrillation, and less than 1% of these patients are saved. This is an advanced resuscitation system. It's called out-of-hospital cardiac arrest resuscitation system, which makes it possible for us to get the patient to the hospital and treat them there. It must be done very, very quickly, and the idea is the chain of survival. In other words, everyone must be able to inform, therefore guarantee early access, and to have early CPR. There are courses which I suggest that you do. You yourselves could save, for example, somebody's life. And early defibrillation, that is to say, to have defibrillators in schools and in airports, is useless because the patient has to be taken to a center that can do more. Here you see the percentages. Without defibrillation, mortality is 100%. With some defibrillation, even if late, 2% survival. With early CPR and late defibrillation, 8%. With an advanced early CPR and early defibrillation, we have a survival around 50% or more. Here we have a hub and spokes system which works quite well, where all the so-called level 3 centers, that is to say peripheral centers, can guarantee some medical support, take them to a coronary unit, and then take them to the so-called hubs, that is to say level 1 centers that have the possibility of implant mechanical assistance systems or other operations. This is the ECMO system. It's extracorporeal membrane oxygenation, cannulate in the two and circulate the blood with a pump, which should maintain flow and perfusion. It's, as I was saying, it's called ECMO, and we use it more and more. Both the technical matters here in this slide, but I'm not going to debate them. And it is a bridge. What does it do? It takes us, in most cases, it is possible to have a complete recovery of a cardiac function. We have about 100 of these, and we have a recovery rate around about 60%. So in most cases you can recover. If this doesn't happen, then transplant or mechanical assistance is the only thing we have. Please have a look at this. This is quite recent, 2019. In the past few years, ECMO has been used increasingly. It's called echo-CPR. You can see how the survival has gone from virtually 0 to about 50% of these acute cardiac arrests. Now, chronic heart failure is something different. This is not a case of a heart that stops suddenly, but that slowly slows down. We have a different classification. Here you can see the Intermax classification. Each one has a definition, which is quite amusing. Number one is the worst, is the critical cardiogenic shock, which is called crash and burn. And certainly this is the worst. These are patients that are declining in spite of drug treatment. So we have a few days at least in group 2, while in group 1 we only have 1. Then we have patients, the frequent flyers, nothing to do with flying, but the ones that repeatedly come back to the heart surgery, those who intolerant to any exercise, they're housebound, and those who exertion but limited, walking wounded. And we know that in this case there's a very high mortality. If a patient with heart failure is admitted to hospital, mortality compared to the general population is much bigger. We have always had a dream, which was not Martin Luther King's dream that everybody should be equal or have the same rights.
We hold these truths to be self-evident, that all men are created.
No, non era questo il sogno.
This was not our dream. The dream that we had was the one which we thought that had been reached when Christian Barnard in 1967 carried out a human cardiac transplant on this patient called Washkansky. He was a young, brilliant surgeon. He was unlucky because subsequently he had suffered from arthritis of the hands. He had to stop being a surgeon and became a promoter for beauty products. Not exactly a glorious ending, but he was the first to use this type of opera. This was the original article. It was called The Operation with a capital T and a capital O. It was a bit sort of overproud. But there is the real father was this other gentleman, Norman Shumway, who was a well-known researcher of the Stanford University in Palo Alto. Some people have met him, I did, and who basically developed all the techniques that were necessary for a heart transplant. Young Barnard, one summer, went to visit and for a time his lab, and when he went back to Cape Town with the easier legal framework that there was there in South Africa, he was able to perform the operation and stole the title from Schuur, but they didn't speak to each other thereafter. They were a bit full of themselves. But in any case, transplant is a very big one. I started with heart transplants as my main activity, and you will observe that you have only 30,000 a year because we lack donors. 22 patients die every day while waiting for an organ transplant. Here you see that we have a total of over 3,000 transplants. We see that we are interested in heart-lung transplant, and we're lucky that we're working in the biggest in Italy and one of the biggest in Europe. And here you can see the number of heart transplants in Italy. It is now around about 200, and this is the number of lung transplants because we also do it. And you see they're still increasing. This is a field that we're very interested. I can see Professor Maggi, who performed the first one in Turin, and we continued along the route that he had set, and I remember this in 2018. We were the most active in Italy with 33 transplants. The problem of organ transplant is the lack of organs. The average waiting time is here about 2 years, for heart one over a year, and for a lung over a year. So kidneys is 2 years. So we have to have all the organs that are possible, because you see that the heart-lung transplant hasn't got the same numbers as liver and kidney, because you can be of any age if you want to give your kidneys or liver but not for lungs and heart. So we have to have transplants from young hearts. This is the second, he was the second man to have a heart transplant in Italy, and the first one in Pavia when I was a student there. I was a Professor Vigano. I helped organize it because I wasn't allowed in the operating room at the time. He was Piedmontese from Cuneo. At the time, he was 17. And last year, he received a transplant in our hospital with a kidney transplant, but his heart had been transplanted more than 30 years ago, and it works fine. One of the longest in Europe. Now I would like to talk about, I hope this is not too gruesome for you, this is a pulmonary lung block. This is these lungs of a smoker, so we can't use them. We are going to try and recondition them. This is an ex vivo lung perfusion. So this is in the field of genetic engineering and regeneration and stem cells. What we can do is, you see, and these were the first in Italy to do this, and we have the largest number, we connect this by a pulmonary block to a perfusion system. We can do this for 5, 6, 7 hours and purify, so to speak, or clean out this organ. Here you can see this is a crystalloid solution with an oncotic power, and we do it to clean out these. After many hours of reperfusion, we have an operating theater. There are many people working on this, many voluntaries, a lot of young doctors specializing. And here you can see the bipulmonary block is artificially ventilated and perfused. We have about 5 or 6 hours to decide whether the lung is good enough to be transplanted. And we decide in these hours whether these lungs can be used. So we can measure the gaseous exchange volumes. In future, I hope that we will be able to engineer the organ, that is to say, to improve it, because we already have studies underway in this. We can carry out a bronchoscopy. Here you see, if we decide that the lung is suitable, we can then transplant it. Now, we were the first ones to do this in Italy, ex vivo lung perfusion, as you see, and we've increased by 30% our transplantability because we have recovered organs, and the same thing is what we're starting to do with the heart. This is a system which is a transmedics system. We have a heart which didn't work very well, and which we have to use. It's a very expensive system, and it is a system that we are starting to use now. Artificial heart. Another one of the dreams that we had. When we talk about artificial organs, we always believe that the artificial organ must look like the natural one. In our approach, we have a sort of anthropomorphism, or somebody says we have bio-inspiration. That is to say, all we build that is artificial must look like the human organ. This was a case in point. This was an artificial heart of the first generation. You can see there are 2 ventricles, so one left, one right. In other words, it replicates the human heart. We've said that the heart is a perfect machine, impossible to imitate it. Probably would also be blasphemous, since our Creator, for those who believe, made it perfect. In fact, these hearts never really worked very well. I remember that I had a discussion with a bioengineer, and you can see this was one of those hearts that he'd invented, but you see these large number of patients with a very complicated machine that worked. this is the end of the 1980s, and this was a system that could not be sustained. There were also a series of problems, technical problems, mechanical problems. And he was saying, probably we're getting it all wrong. If we want to have a heart that works, we have to forget the human body. So we should not be anthropomorphic, but we have to think of something different. And the idea came from industry. Again, the weapons industry. The word here, there's also a compendium of industrial and farming technology. But what we understood that had to be different is that heart can work like a turbine. With the principle of Leonardo's unending screw, but we have the possibility with the systems, mechanical system, of impellers that rotate at a very high speed. We have the possibility to generate a flow without this having to be systolic or diastolic, and without have valves that cause thrombi and problems. And the solution was that of using systems with magnetic suspension that would generate a flow, suspended and rotating at high speed. This is the artificial heart that we use nowadays. Simple, no valves. It's an electromagnet with an impeller, and that does not touch blood.
A flusso laminare. E questa, vedete, è stata alla fine la soluzione, quindi dimenticandosi di come è fatto il cuore
we
umano.
did this forgetting how the human heart is built. 10 liters suspended in a magnetic field. It doesn't move, which was like the one which was a previous model, and the flow is perfect. It is hydrodynamic bearing blood flow. Minimal problems of compatibility, biological compatibility. It goes from 2.5 liters per minute to 10 liters per minute, and normally we need 5. So it's a very strong system with this system that maintains full levitation and does not damage red blood cells. So we've gone from these hearts that looked like the human ones to miniaturized system that you can hold in your hand, and that's not a metaphor. You can actually hold them in your hand. This is a very system, taking the blood from the ventricle. Here you have to put the cannula and take it into the aorta without touching the elements of the blood. Here there's a problem. Here you can see that this is a lead, and because the heart requires energy. And one of the problems of these systems is that they need a lead. It's a bit of a problem for a patient. There are about 50 people that have these systems of mechanically assisted heart pumping, but the problem, Achilles heel, so to speak, is that you need a lead for power. And this gives a series of infections and so on. So already in 2001, and here I'm referring to what I did, we tried to bypass this problem using, this was a very primitive heart, if we look at it with today's eyes, and it was anthropomorphic, and it could be implanted. All the components could be implanted. Surgically, it was a big problem. It was a very invasive operation, but basically there was a battery, and it was recharged with a coil that was implanted under the skin. And this idea that it was a transcutaneous energy transmission system through the skin was tested. 5 patients survived for a few years with this system. Then this heart was completely discontinued because it caused another series of problems which I'm going to describe, but it says it taught us that it was possible to transmit energy, so much so that we had imagined that in the future patients with an artificial heart could circulate at home with Wi-Fi sources of energy and a coil under the skin to store the energy. Well, this is the future. Well, actually, it's already happened. It happened last year. This is a patient from Kazakhstan who was the first one to receive this implant, this new implantable device. It's a rotary pump. His name is Ismail. In Kazakhstan, they've got a lot of money, big investments, thanks to oil. And this fully implantable is a small turbine at the apex. There is a subcutaneous coil. This is the team. There's also an Italian surgeon, and here you can see Professor Massetti, and here there is the main surgeon, a Czech surgeon, and it worked. The patient was able to stand up, walk. This is the internal coil that was implanted, and this is the external sort of ring that he has to wear. He can take it off for about half an hour to an hour. So one thing he can do is with an artificial heart, he can take a swim. Now, let us talk about something different. That is to say, tissue and cell engineering. Just a few words, because here I would be embarrassed by all of this. The problem of heart regeneration is something that has been mentioned for many years. In fact, we're still quite far from a clinical solution of this. The notion which is most fashionable is that of decellularizing a heart and then recellularizing in another way. This was done in small animals. It has been done. You inject a series of enzymes that will digest the tissue, just leaving the architecture, that is to say the collagen, and then you have to repopulate it with cells that have to differentiate in all of them. So decellularization, recellularization, and it's been done only with small animals, and the results have not yet been satisfactory. But the big chapter of the engineerization of organs is our future. As far as our clinical engineering is concerned, putting together and cooperating with other centers, is that we have a perfect model of possibility of gene therapy, which is this system. This is an artificial heart, the one that we normally put. The problems of these hearts is that they last 5-6 years, but it's a mechanical system that has to be replaced. And it's not that simple to replace them. Ideally is to implant when there's a heart failing, and during that phase, in some way, to induce a positive remodeling of the heart, so that the recovery is complete and that the heart can be removed. And lastly, xeno-transplants, xenografts. Is it possible to use an animal to save a human life? It's possible. I didn't mention it because I'm a bit, and not many people know about it. The first one that was ever tried was a rather mad surgeon. Surgeons are sometimes mad, from the southern part of the U.S., James Hardy, operated on a little girl whom had extracorporeal circulation, and he took the heart of a chimp and transplanted it. Clearly, the little child died. This was 1964, so 3 years before Barnard. She died because there was a hyperacute reject of the new heart. Now, this was the second attempt in 1984, baby Faye, that had a transplant in Loma Linda,
trapiantato utilizzando sempre il
and
cuore
they used
un babbuino, in realtà
the
anche
heart
in
of a
questo caso
baboon, but in
la-
this case
la funzione
too,
durò poca. Si è riusciti
it
a
didn't
superare
last
il
long.
concetto del rigetto iperacuto,
But
peccato che superato quello
unfortunately, once she'd overcome the reject, but nature raises another type of reject, which is something that doesn't happen when you have it from human to human, which is a particular type of vascular reject, which is not fully understood. So this attempt was stopped. This route was closed. Maybe a solution for the future, I don't know. There are two tendencies, that is to say, to have an immunological tolerance, or is to have a genetic engineering of the organ that we're going to transplant. In 2002, in the US again, they created the first transgenic pig, cloned pigs, where they had eliminated a modified pig that lacked the genes that were the ones that triggered the reject. And so they started from pig to chimp. Results are not brilliant, and then there's a problem, which an unexpected problem that has arisen, and that is that of the infection. People are talking about viruses, that normally are not, of retroviruses that are normally not bad for humans, but which could become deadly or fatal if they were carried by the heart. But something else is an immune tolerance, treating it with stem cells of the pig, in this case, creating what we call a chimera. A chimera is a mixture between two animals. In this case, don't make too many jokes about humans and pigs, but this attempt too has not given satisfactory results. I always mention what Sharma says about xeno-transplant when they asked him what to do, since he had done things from human to human. He said, very nice, but it is the future of transplants, and it will always be. So if I had to bet on xenotransplant or mechanical heart, I would put my bets on an artificial heart. And I will now conclude. I have brought you in this across this technological journey. This is a very famous drawing of Raphael's, the School of Athens. But to say that other than all the technology that we've seen, in fact, our mission as doctors and surgeons is to reduce pain, and it's a human role where the patient is at the center. And to reword, this is a sentence that Steve Jobs appears to have said, I would say, I would trade all my technology for an afternoon, not so much with Socrates, but with an evening at the School of Athens with Aristotle and Plato. Thank you very much for your attention.
Grazie professore.
Thank you very much.
Abbiamo tempo come sempre per qualche
We
domanda
have
dal
time
pubblico.
for a few questions.
C'è un microfono che gira.
There's a roaming mic. You spoke of the fact that there is an age limit for donors. But my question is there also an age limit to be a receiver? Yes. It is not a very rigid one. Usually what we use is 65, between 60 and 65, and then obviously the biological age and comorbidities, but on the whole above 65, transplant
tenete conto che dopo un
doesn't
trapianto
get brilliant
bisogna assumere
results,
dei
and after a
farmaci
transplant
che
you
in
have to
qualche
take
modo
drugs
sono
which
tossici, farmaci
are
immunosoppressivi
toxic
che ci preservano
because
dal
they're immune
rigetto, e
suppressors,
quindi in un'età
stop
molto
reject, but it's
avanzata, sicuramente sopra i
I think
65
if
è
you're
raro. Abbiamo
over
fatto qualche
65 it's
trapianto fino a
rare.
70 anni
Up
di
to
cuore,
70
e
we've
ugualmente
done
il
it,
polmone
but
intorno ai 65,
lung to
66
65,
anni. Questo è il limite.
66. But that's normally the limit. I have a question. You were talking about
Sì.
eccentric doctors in heart surgery, but not just that. One of the things that is not being mentioned is the self-experiment, that is to say, to experiment techniques such as, yes, the first catheter in cardiac catheter was an auto test. Is it still so, or for the level at which we are, it's not possible? No, very difficult.
Sì, dico sempre che se dovessi ripararmi
I
la
always
mitrale,
say that if
potrei
I
farlo
had
da solo,
to
in questo senso.
repair my
Però,
mitral valve, I'd like to do it myself, but
no, mi fido.
I don't. You do
però,
not trust
sa
surgeons?
com'è?
Well, no, I
è
trust
che-
them, but you
è
know,
che è difficile immaginare
no,
di
it's just difficult
autosomministrarli. Il caso del catetere
to
cardiaco
self-administer. The case of the
fu
catheter,
ma in quel caso fu perché
but in that case it
nessuno
was
si
because
sottoponeva a
no
questo tipo
one
di esperimento, e quindi
would accept that
decise di
experiment.
dimostrare
And
che
so
era
he
possibile
decided
arrivare
to
al cuore
prove
da
that it was
veine.
possible to reach the heart from a peripheral vein. German doctor, wasn't it? Yes, sportsman, yes. And with a catheter from his femoral vein, he reached the heart. But once he arrived there, he didn't know what to do.
Certo, ma
The
infatti
problem was
la
getting there.
navigazione
Yes, in fact,
intravascolare, avete visto adesso con
intravascular
questi
navigation,
sistemi,
as you saw it with these
di
systems
immagini,
of
veramente di
images,
elevatissima qualità,
which are
adesso
very
la
high
regola, ma
quality
allora
images,
era
is
veramente
the
un'eccezione,
norm,
e
but
poi,
then it was the
non si
exception,
sapeva cosa
and
farne.
we didn't know
La
what
prima
to do with it.
applicazione in
The
campo,
first
cardiologico,
application in
cardiochirurgico
the
fu
heart
l'angioplastica
in heart
coronaria.
surgery was angioplasty. Grunzing, the first a Swiss cardiologist from Zurich, invented this system with a balloon with which it was possible to dilate, navigating from the femoral one to the femoral vein to the coronaries, and it has remained one of the most effective treatments for an acute myocardial infarction. Thank you very much, Mauro Rinaldi, Piero Bianucci.
Grazie molte, grazie mille.
Grazie e arrivederci.
Thank you, and see you next week.
Buona serata a tutti.